Well, good morning, good afternoon, good evening to all of you. Um, Thank you very much, Dr. Fernandez, for giving me the opportunity to present at this forum. My name is Rohit Ramaswamy, and I am currently, I work at a academic medical center. I work at Cincinnati Children's Hospital, but I come from a public health background. Just last year, I left the University of North Carolina, where I was teaching at the School of Public Health. A lot of the work that I do is at the intersection of research and practice. Part of my role, my new role at Cincinnati Children's Hospital, is to be able to bring implementation science into an organization that has a very strong quality improvement program. And so what I'm going to talk about today comes from years of work in global settings. I continue to work in Ghana and in India and in South Africa, both in terms of capacity building for implementation research and implementation science for researchers and practitioners, but also working with health systems to improve both kind of improve the quality of health services and processes, but also to build capacity in implementing and sustaining what has been improved. And so that is the context within which I'm going to talk today. You will find in my presentation today both kind of connections to what Dr. Fernandez presented earlier. You'll hear language about outcomes and determinants and strategies. It's also linked to the kinds of things that Dr. Geng talked about in terms of how do we create a science of implementation that is useful for low-income contexts. How do we look at how the kinds of things that practitioners are interested in, which is how do I implement programs? How do I make a difference on the ground? How can we begin to use some of the ideas of implementation science to be able to advance some of those questions? So I'm hoping that my talk will serve as kind of a thread to connect what you have already heard, but will also introduce some new concepts to you. I don't know how many of you have a knowledge of quality improvement as a field. The WHO, of course, has been very actively involved in promoting QI as well in global settings, and a lot of the work that we do uses WHO materials for quality improvement. So what I will do is to start with a basic introduction to quality improvement and the most common model that is used in global settings. I will talk about what that model is typically used for, providing some examples of how it has been used in some of the projects that I've worked in, and then talk about how we can take the quality improvement model and extend it by incorporating into it principles of implementation science, and how that extension of implementation science basically serves to integrate the fields of quality improvement and implementation science. One of the kinds of things, over the years, because these two fields have grown up differently, and because they've come from different backgrounds, there has been a tendency for those who are quality improvement experts to think about implementation science as something that is different and separate. And there has been a tendency for implementation scientists and researchers to think about quality improvement as nothing more than an implementation strategy. And so some of that is changing again. I think there has been a greater recognition that these two fields have more in common than they are different, and that being able to think about these two fields in an integrated way allows for not only for developing solutions to improve quality, but it also allows for thinking about how to be proactive and planful about implementation, even as we are beginning to think about improvement. And so those are some of the kinds of things that I'm going to talk about today. So the basis or the foundation from which I'm starting is that a lot of the organizations that I work with and a lot of the organizations across the world, from a practice-based setting, as they're thinking about how can we improve the quality of services that we provide. The reason that they want to do that is that they want to be able to change their systems. So the idea is that my current system is not working, it is not providing the outcomes that I need, the processes are not effective, the processes are not efficient. How then do I change my systems in order for it in order to make sure that it is working better? And so the quality improvement movement has been has existed over the last 20 or 25 years to bring about systems change. What I'm going to talk about is it is great to be able to think about ideas for changing systems. It's great to be able to think about change solutions, but it's not enough just to have these ideas. These ideas need to be implemented. These ideas need to be sustained. These ideas need to be scaled up. And this is where the implementation science principles become important. And so the way that I think about how to integrate quality improvement and implementation is in this formula. And this formula is an adaptation of a formula that has been used by one of the foremost implementation science organizations that's based out of the University of North Carolina called NERN, National Implementation Research Network. But the basic idea is that if I want to have successful outcomes, I need to have two things. I need to have change solutions. I need to have an intervention that has been tested. And as Dr. Fernandez says, and Maria said, perhaps these are done in kind of carefully controlled efficacy trials and then in effectiveness trials to see if they're actually working in the real world. But I need to have something that works. And the idea is that these things that work are like the seeds. They are the ingredients, the essential ingredients for bringing about systems change. But it's not enough just to have the seeds. What we need to be able to do is we also need to have a farmer who takes care of the seeds, who sows them in the right context, to make sure that the soil is right for their growth, who's able to water them, who's able to provide the fertilizers. And it is this kind of tending that is the implementation. And so we need to think both about having the right interventions, having the right solutions, and also having the right implementation. And that's where these two fields come together. So I had this slide that you saw. I didn't realize that Dr. Fernandez was going to share this slide. So this is the slide we talked about in terms of how do we differentiate between the intervention and the implementation. And so as Dr. Fernandez said, we are looking at the idea of using implementation science is to take a change solution, a change package, an intervention, and be able to put it into practice, put it into everyday practice in our programs, in our policies, in our clinical guidelines. And so through my presentation today, I will be talking about both the change solution, which is the thing, which is the intervention, and the implementation strategy, which are the kinds of methods that I need to put in place in order to make sure that my change solution, my intervention works in everyday practice. So let's start with what a change solution is. And I'm going to take a broader, as somebody who works in both in practice and research, I'm going to take a broader view of what change solutions are, because in a lot of the settings that I work in, and a lot of the global health settings, for example, in hospitals, it's not always that my change solution is a research intervention. As far as possible, we try to bring evidence-based interventions into use. But for a variety of reasons, for example, there might be no evidence, or the evidence might come from a different context and might not have been appropriately adapted. Or this might be institutions that have local problems that are looking for local systems changes. So the way that I think about the use of implementation science is not only that we need research interventions. Obviously, research interventions are useful and important, but there could be a whole variety of other solutions that need to be put into practice. Over a period of time, obviously there needs to be some careful thought about whether some of these other change solutions are really result in outcomes. We do need to have some tests in place to make sure that they're appropriate and that they work. But I want to emphasize here that when we begin to think in practice-based settings about, what is it that needs to be implemented, it could be a variety of different things. So it could be evidence-based research interventions, but it could also be local clinical experience. It could be client preferences. So this could be an intervention that is already in place, but that needs to be adapted or changed because the patients or the community, it's not acceptable or appropriate for the patient or community. It could come from kind of organizational culture. There could be barriers to implementation that require me to think about how do I come up with local solutions that are culturally appropriate. So there are a variety of different ways in which I could come up with change solutions. But the bottom line is each of these need to be implemented. Each of these need to be put in place if they have to work. And so let me start with quality improvement. So we think about very broadly as the quality improvement as a process for effective interventions. And these could be, and the QI process, this particular model is called the model for improvement. And many of you might be familiar with the model for improvement, but this is the standard model that is used in a variety of settings around the world. And this is the model that the WHO has also advanced as a way of thinking about systematic way of approaching developing interventions that might be locally appropriate. And so this model for improvement can actually be used both for taking an evidence-based intervention and changing it and adapting it so that it fits the local context. So this doesn't mean that a QI process has to be always start from the ground up. But there could be situations, as I said, where if we don't really have an evidence-based intervention, then the quality improvement model, the same set of questions can be used to generate solutions that work. And the idea, of course, is that the reason that we have a quality improvement model is that we can't just go ahead with any solution just because somebody thinks that this is the right solution. We need to think about how are we going to approach the creation of if we are going to create local solutions, or if we're going to adapt evidence-based intervention, we're going to need to think about how do we do that in a systematic way. We're going to need to think about how do we approach the creation of local solutions as systematically as though we were doing research to confirm evidence about a particular intervention. And so the model for improvement essentially takes a team through 3 questions. What are we trying to accomplish? What is the goal of what we are trying to do? If we're trying to change systems, if we're trying to make things better, can we be precise and develop a goal that allows us to be able to say what change do we need to have, what change needs to happen? The second question is, how will we know that it changes improvement? So what is the data? We have to be able to think about using data to understand whether our changes are working or not. And ultimately, the third question is, once we've got our measurement, once we've got our data in place, what are the kinds of things that we can do that will result in the kinds of system changes that will bring about improvement? And then the plan, do, study, act cycle that many of you might be familiar with is the way that we are beginning to test some of our ideas in the local setting. So this is an iterative process of testing, an iterative process of using data to see what works and what doesn't work, and using this iterative process to be able to assure ourselves that any solution that we come up with, whether it is an adapted solution from someone else, whether it is an adaptation of an evidence-based intervention, or whether it is something that I've locally generated, whether it is going to work in my setting or not. And so when we think about more broadly about kind of these questions, there are particular components that we want to be paying attention to that I want to emphasize here, because we will see how these same kinds of components manifest themselves when we're talking about implementation as well. So when we think about the question about what we are trying to accomplish, the key component is the improvement goal. What is it that we're seeking to improve? When we're asking the question, how will we know a change is an improvement? This is saying that we need to have appropriate measures in place. And Dr. Fernandez talked about both process evaluation and outcome evaluation. When we talk about improvement measures, it's the same kind of thing. We need to have outcome measures that says, how do we know that our outcomes have changed? But we also need to have process measures. How do we know that What are the kinds of things we need to measure along the way to the outcomes that will help us to better understand how the intermediate processes are working that result in outcomes. And ultimately, the third piece, which says what change can we make that will result in improvement, this is where the science of improvement comes in. The science of improvement says that we need to be able to think about an improvement theory that we need to have in our mind from either from our knowledge of the literature or our knowledge of what others have done or our internal knowledge of our own context. We need to have a theory. We need to have a theory of change. And so this theory of change then allows us to be able to come up with a set of change ideas that we test using the PDSA approaches. And so I want you to keep these three things in mind: the goal, the measures, and the theory are the three things that drive a quality improvement approach. And if we do this well, if we have an appropriate goal, if we have the appropriate measures and data, if we have a theory that we are testing using the PDSA approach, it allows us to have a good level of confidence that the solution that we have generated, the intervention that we've generated, the system change idea that we have generated is appropriate for our context and that it is likely to work in our context. And the reason I want you to keep these in mind is because we will come back to these three components as we talk about implementation. I wanted to give an example of how these kinds of quality improvement methods are used in global settings. This is some work that we've done in Ethiopia. We've done similar work in India and Ghana, a lot of it in maternal child health concepts. And the idea is that we're using, so as I mentioned earlier, the plan, do, study, act cycle, the PDSA cycle is not a single point process of testing. It is an iterative process. And so what we did in Ethiopia is the idea is to improve maternal and neonatal health outcomes. And what we did here, and this is a common process that is done in many countries, the WHO supports this kind of process. We provided QI training for facility leaders. We conducted baseline assessments on where there were key clinical gaps and operational gaps that resulted in poor outcomes. And then we trained quality improvement teams. The local teams trained quality improvement teams, and the quality improvement teams developed ideas, change ideas for testing. So there was a learning session where these ideas were discussed, where the measures were put in place, and then the action periods were where the actual ideas were implemented and tested during PDSA cycles. The teams got back together in the learning sessions to identify, to share what was learned, to share what worked and what didn't work, to be able, Dr. Fernandez talked about the diffusion of innovation, to be able to use these learning sessions as a way to diffuse ideas that are promising and have them tested in other sites. And so over a period of time, over a period of 18 months, in 4 districts, these QI practices were implemented. There were 4 learning sessions and multiple action periods. And as a result of which there were some changes and improvement in processes. They didn't necessarily result across the board in improved maternal neonatal outcomes, but they resulted in changes to the way that clinical care was provided. They resulted in changes to the way service delivery processes would improve. So there were some process improvements in place. So I just wanted to present this as how the model for improvement that I talked about earlier is actually put into practice. So I just wanted, just for a little bit of a break so that people are not just hearing me talk, I wanted to talk a little bit about how we might think about using the model for improvement in other settings as well. So this is an example that I have shared that we have used in other learning sessions, especially kind of during COVID times. And so the WHO 5 moments for hand hygiene, for example, is something that is well known to everybody. And so what we've talked about is, suppose there is especially in 2020, when it was unclear whether COVID-19 spread through airborne particles or whether they spread through physical contact, there was a lot of effort to improve hand hygiene and to make sure that there were appropriate hand hygiene practices in a variety of different settings where the public was. And so one of the examples that we have been thinking about is if you're working in a grocery store, if you're working in a supermarket, if you're working somewhere where it's not a hospital setting, but you still have a lot of people coming in, you have a lot of people touching a lot of things, how can you develop a hand hygiene policy for staff in the store? And the model for improvement, so most of you are familiar with these 5 moments of hand hygiene that are applicable in hospital settings. So of course, before the patient contact, before you're doing any kind of aseptic task, after any kind of body fluid exposure, after patient contact, after contact with surroundings, these are the kind of evidence-based practices or good practices associated with hand hygiene in hospital settings. And so the question becomes, if I have this as my evidence-based intervention or common practice intervention that has been applied in hospital settings, what do I need to do in order to be able to adapt this intervention for use in grocery store settings? And this is a perfect example of how the model for improvement can be used, because the model for improvement allows me to take a solution that already exists and think about how can I apply it to my context. So for example, in this case, we might have an improvement goal that says, I want to be able to improve the compliance of hand hygiene amongst the staff in my grocery store. In much the same way as we have in a hospital setting, we have compliance or adherence to hand hygiene protocols by the staff for providing patient care. So we can have an improvement goal now that is a grocery store focused improvement goal. Then we can think about some improvement measures. What are some appropriate improvement measures? Obviously, the improvement measures would be different from the patient settings, but we can think about how do we adapt the patient setting, the different patient setting moments to grocery store moments. So when we say before patient contact, perhaps the equivalence here is every time that I am touching something that a customer is handing me, for example, cash, or the customer is handing me a credit card, I need to do hand hygiene. Similarly, if I am doing something that is related to contact with patient surroundings, the equivalent here is if my groceries, but the shoppers in my grocery store are walking around and touching my products, I might want to be thinking about having hand hygiene after I touch those same products or after I load these products on the shelves, right? So, and therefore we can create some improvement measures that allows me to be able to check and measure whether these hand hygiene moments are being followed. And basically then thinking about what is the improvement theory. The improvement theory might be to say, let me look at the geography of my grocery store. So just like the 5 moments of hand hygiene are based on the geography of patient care, of how a healthcare provider moves within a patient space, let me think about what the geography of staff movement through my grocery store is. And I'm going to use that to be able to say, what are the drivers? Where are the places where the staff are most likely to congregate? Where are the places where they are most likely to be in contact with people who might be infected? Where are they most likely to be in places where they are likely to get infected through contact? And these are the places where I need to think about both reinforcing hand hygiene habits, as well as perhaps kind of placing hand sanitation kits. So that is my improvement theory. And so as a result of my improvement theory, I'm going to come up with a set of change ideas or a set of solutions that have adapted WHO's hand hygiene protocols to the grocery store. And that is my change solution. So that's where the model for improvement can be used. And this is how we use quality improvement in a lot of our healthcare settings around the world. We use it to improve both operational processes. So for example, how quickly we see patients. We use to improve clinical processes. making sure that we're providing the right level of care or the right type of care. We use it to improve leadership processes. So perhaps we use it to improve decision-making. We use it to improve communications. And often what happens is that the quality improvement work results in a whole bunch of change ideas that then get dumped on the organization. So because there isn't a well-established implementation science approach in many of these institutions, what we find is that these ideas are, everybody is super excited. Everybody is interested in, especially if done well, QI efforts lead to great engagement and lead to all of these ideas that get documented on flip charts. But when it finally comes to implementation, they don't get implemented. And so this is why we have, over the last few years, thought about how do we now take the model for improvement, which has served to be a really good way of thinking about identifying change solutions. How do we extend it to think about implementation as well? And so what we have done is we've worked with these organizations to create what we call the model for implementation, which is analogous to the model for improvement, which has the same kind of structure, but which now focuses on implementation science, implementation questions, rather than evidence generation or improvement questions. And so, as we said, we are in a situation where we have these tested change solutions, but we don't have implementation. I'm not actually going to go, this is an example that I've used in other settings as I've taught the model for implementation. In terms of, because we don't have a whole lot of time, I want to move directly to model for implementation. But these slides will be available to you. But here is an example of a global study that was conducted of surgical safety checklists. And the WHO, of course, has, and Dr. Atul Gawande have promoted the surgical safety checklist as a way of reducing global mortality and morbidity. This was a study that was done in Ontario about the use and the effectiveness of surgical safety checklists. And basically they found that across across 101 hospitals in Ontario, the overall effect size associated, aggregate effect size associated with the use of surgical safety checklists in reducing mortality and morbidity was 0. And that was because the idea was that it was not so much the surgical safety checklist as an intervention didn't work, but the way that it was implemented across these 101 hospitals was widely different. And so the conclusion was that it is great to have a wonderful intervention like the surgical safety checklist, but without effective implementation, basically it is just a tool. And so I'll talk a little bit later about some global work that has been done to improve the implementation of the surgical safety checklist. But I just wanted to present this as a way of demonstrating why you could have the best QI process, but ultimately at the end of the QI process, if you don't have a good implementation system, things don't work. And so I'm going to start my introduction to the model for implementation with a quote by Dr. Joseph Durlak, who's one of the pioneers of implementation science, who said, when it comes to implementation, what is worth doing is worth doing well. So it is not just about thinking about, oh, implementation is something I need to do. I have these ideas, I'm going to just throw it on the local staff or the frontline staff to implement because it's their job to do it. But we need to be able to think in a systematic way about how to do it well. And so this is where the model for implementation comes in. And the model for implementation has the same kind of structure as the model for improvement. At the end of my presentation, I'll show you how these two things come together. But for the moment, the model for implementation has 3 questions. And you will see that these 3 questions are analogous to the questions that we asked for improvement. What implementation goals are we trying to accomplish? So what is it that defines, how do we know that our implementation is successful? And then the first question is, what is it that we want to achieve? What is our implementation goal? The second question is, how do we know that we've accomplished this implementation goal? So again, thinking about what kind of process measures do we need? What kind of outcome measures do we need in order for us to be able to measure the quality of implementation? And then finally, what strategies are needed to achieve the implementation goals? And this gets us into the world of implementation strategies. And just like from a quality improvement perspective, we had to test the change ideas that we came up with to make sure that they were working in our context. We use the same plan, do, study, act approach, the PDSA approach, to test the implementation strategies so that we can make sure that they're appropriate and that we adapt them appropriately for our context. So this comes, therefore, as an analog to the model for improvement, the model for implementation has 3 implementation questions. It has the implementation goal, it has the implementation measures, and it has the implementation theory. So the question is, how do we take these 3 components and relate it to implementation science? How do we relate it to some of the terminology that Dr. Fernandez talked about earlier? How do we to link it to theories, models, and frameworks that are related to implementation science? I'm not going to talk about frameworks here, but you should keep some of these things in mind as I talk about how now we take some of these questions and how do we make them applicable to the context of implementation science. So the implementation goals, when we talk about implementation goals, these are nothing different, nothing other than the implementation outcomes, Dr. Proctor's outcomes that Dr. Fernandez talked about. So when we begin to think about implementation, the first thing we want to be paying attention to is which implementation outcomes are relevant to us. And so the kinds of things we might want to ask, there are 8 outcomes that Dr. Enola Proctor has identified. Here are some that we have found to be common across many of the settings that we've worked in. So you want to start asking questions about, before we begin to think about implementation, is it going to be acceptable to stakeholders? Is it going to be agreeable and satisfactory? Is it going to be feasible? The resource constraints are always one of the question that was raised about that it takes cost, it takes time and cost to implement. Do we have the appropriate resources for implementation? Do we have to make sure that we're lining up those resources first? Thinking about adoption, even is the organization ready for implementation? Even if it's acceptable to the staff, even if it's acceptable to the patients, is ultimately the organizational culture going to be such that the organization is going to be resistant to change, and therefore it's not everybody in the organization is going to adopt it. Questions of fidelity. Can we make sure that we have the infrastructure in place so that the change solution, the intervention is appropriate, is implemented in the way that it should be implemented, right? So what we want to start asking as we're thinking about using the model for implementation is asking which of these goals is relevant to us. And part of this is that different goals might be relevant at different times in your implementation process. So if I've not implemented anything at all, then I might first want to start thinking about acceptability and feasibility. If I've already started implementing and I know that implementation is working, then I might want to start thinking about adoption. What are the kinds of things that are affecting my ability to adopt and sustain more broadly in the organization, right? So the first question is where you're linking this idea of implementation goals to the implementation outcomes and implementation research. The second question then, in terms of how do we know we have accomplished them, there are 2 things. First of all, we want to be able to measure the implementation goals. So in the implementation science literature and the resources that Dr. Fernandez talked about, there are many papers about how do we measure acceptability, how do we measure feasibility, how do we measure adoption. And so taking a look at some of the ways in which others have done it and thinking about how they apply to my context or developing measures for my implementation goals, that is an important piece associated with how do we know if we have accomplished our implementation goals. Then, as Dr. Fernandez talked about, there is also the process. So as we begin to think about our implementation goals, we might want to think about what are the barriers to our implementation. And this is what gets us into the determinants. The CFER framework that Dr. Fernandez mentioned is called a determinant framework because it allows us to think very broadly about the kinds of factors that affect our ability to implement successfully. And so there are a variety of different factors. There could be environmental factors, there could be organizational factors, there could be provider factors. Each of these might be different in our settings, and each of these might manifest themselves in different ways at different times. But beginning to think about, and so if I have a goal of acceptability, for example, I think that I need to make sure that the change solution that I've come up with is acceptable to my providers. Then I want to be thinking about what might be the organizational factors that affect acceptability? So maybe, as we said earlier, there might be an issue of change tolerance within the organization. Maybe there are provider factors. Maybe the providers themselves are not confident about the intervention, and therefore it's not acceptable to them. So being able to think about these factors and how can I measure these factors, this is analogous to in the quality improvement world as we're having outcome measures and process measures, thinking about the implementation outcome measures and thinking about the process measures that come from these determinants is a way of helping me understand how to monitor the progress of my implementation. And then once I've got these measures in place, analogous to the improvement theory and thinking about what change can I use that will result in my system improving, I ask the question, what kind of implementation strategies do I need to put in place that will address the barriers that I've identified that will help me achieve my implementation outcomes? And implementation strategy, as Dr. Fernandez mentioned, is a method or technique that is used to enhance adoption, implementation, and sustainability of intervention. And so it is different from the intervention itself. I use the model for improvement to come up with the interventions, and I use these implementation science questions, the model for implementation, to think about what my appropriate implementation strategies are. So so we talked earlier about the notion of theory, right? Thinking about we need to have a theory that helps us to determine how am I going to approach the process of improvement. In the same way, it's also important for me to have an implementation theory that allows me to be able to say, how do I approach the process of implementation? So here is an example of an implementation theory that we developed to implement an obstetric triage program in Ghana. This is in 8 facilities in Ghana. And basically what the obstetric triage program does is when a mother comes into a health facility, she's assessed for risk. And then based upon her risk assessment, she's banded. So there is a red, yellow, or green band, depending on the level of risk. And then based upon that risk, there is a care plan that is provided. So the mothers who are at higher risk are provided a care plan that is suited to their particular risk context. And so as we were beginning to, so this is a intervention that was developed through a quality improvement process and then reinforced with literature from other settings, from high income settings. So we had an intervention that consisted of an assessment, consisted of banding, it consisted of care plan development. So now that we have this intervention, the question is, what is our implementation theory? How are we going to approach our implementation? And so we created, in working in conjunction with these facilities, we created this multi-level implementation theory. This multi-level implementation theory basically says there are 3 different components of implementations we need to be paying attention to. The first component of implementation is within the facility itself. So within each facility, we need to make sure implementation takes place well and that the quality of implementation is monitored. So the implementation outcome that was selected was fidelity and acceptability. And the implementation theory said, what you need to do is you need to be able to create a set of champions. These are the people who are leading the implementation process, whose role it is to monitor the quality of implementation, whose role it is to continue to check for acceptability and fidelity, and then whose role it is to use a variety of implementation strategies. So this could be training strategies, this could be coaching strategies, this could be incentive strategies that will then allow them to implement the obstetric triage well, so that the ultimate goal of implementation, complete implementation with fidelity is achieved. So that's the within facility strategy that you see in green here. At the same time, we also said, as part of, in order to accelerate this process of change and in order to accelerate what works across multiple facilities, we also need an across facility strategy. And across facility strategy was this creation of learning networks. And these learning networks brought together, and this is very analogous to what you saw in the Ethiopia example I said earlier, where the learning networks were used to identify what worked around change interventions, around change solutions. In this particular case, the learning networks were brought together to discuss what works in implementation, what implementation strategies are working, and how do we adapt some of the implementation strategies that are working in one setting for use in other settings, because the geography of each of these facilities is different. The way in which the labor wards are organized in each of these facilities is different. The way in which patients flow through these facilities is different. So even though there was perhaps there's an implementation strategy that says, place a reminder, a poster reminding what the steps of the triage process are at the entrance of the facility. The entrance of the facility is different in different facilities. And so the adaptation was, where do we actually need to put the poster, right? So we had this across facility theory. And then ultimately, at the health system level, the idea is that if we really want to scale up, it is not enough just to have the individual facilities involved, but it is important for us to make sure that we are also involving the health system. And so we established, as part of the implementation strategy, a set of national champions. And these national champions were part of a steering committee that was providing advice to both to the implementation team, but also providing advice to the leadership of the different facilities to enable barriers to implementation to be addressed. And so the whole idea is that coming in with this implementation theory, we selected strategies from the implementation science literature. These are a set of strategies. These are the set of strategies that have been developed over the last 10 years by Dr. Byron Powell and others, that have been shown to have been used in a variety of different settings. So we went through the list of strategies. We selected particular strategies that seemed appropriate to the settings. And then we used the model for implementation to test these strategies. So the point I want to make is that we've talked so far about implementation science as a research field. And certainly when we think about implementation science as a research field, these strategies, the kinds of things that people do around the world, this comes as a result of a research process. But all of these, the frameworks that we talked about, the determinants that we talked about, the strategies that we talked about, the outcomes that we talked about, all of these are also equally applicable in practice because they allow us to help, they help us to move forward the process of implementation. So I wanted to show this slide as an example of how implementation strategies have also been used in other settings. So here's a paper that talks about how they've been used in the surgical safety checklist around the world. So the fact that the Ontario study identified earlier on that implementation strategies were not, that the implementation of the surgical safety checklist affected the outcomes. Now the WHO has sponsored a lot of studies around implementation strategies for the surgical safety checklist. And what you're seeing here in these colors are coming back to this list, the different types of strategy, the groups of strategies that have been identified as ways in which implementation can be improved. And so as you're seeing here, across these different categories, there are a whole variety of studies that show how implementation strategies across these different groups have been tried for the surgical safety checklist. So the point of this is that it is not just in some of the work that we've been doing, but the idea of beginning to think about using strategies in a variety of other global health applications has also gained popularity. And so there are other places that you can go to get a sense of how some of these strategies have been used. And then finally, just like we talked about using PDSA to test the change solutions, we use PDSA methods to test the implementation strategies. So what we did in Ghana is that in each of the facilities, the midwives, the frontline staff came up with implementation strategies from the list that would improve the fidelity of implementation. And then they tried these out using PDSA and they adapted them as necessary to fit the local context. And then these adaptations were shared through these learning networks to come up with a set of integrated national strategies that are now being documented and are becoming part of national policy for triage. So again, this idea of testing on the ground using a systematic approach model for thinking about how to do implementation has shown to be successful in bringing better implementation into practice. So let me end, because I only have a few minutes, with how therefore do we bring these two things together? And so in some of the work that we have done in the past, we have continued to promote this idea of integrating systematic implementation with quality improvement approaches, so that we're not only coming up with the right change solutions, the right interventions, but we're also thinking about how to implement them well. And so this is how the two pieces come together. I showed it to you as two separate pieces, but this is how the two pieces come together in what we have created as what we call the model for improvement and implementation. And as you can see on the left-hand side of this model are the model for improvement questions that says, what are we trying to accomplish? How do we know the change is improvement? And what changes can we make that will result in improvement? And on the right-hand side is the model for implementation with implementation questions. What implementation goals are we trying to accomplish? What are our implementation outcomes? How do we know we've accomplished them? What data do we need to collect on these implementation outcomes, and what data do we need to collect on the implementation determinants? And then what strategies are needed to achieve the implementation goals? And the PDSA is the workhorse that sits in the middle of both of them. So I'm using PDSA either to test my change solutions, to test my interventions, or I'm using my PDSA to test my implementation strategies. And the other thing that I want to point out is the arrows between these two parts of the model. So it's not as though there is you always start with the left and you move to the right. These two models are actually in their application, they need to be integrated because they're two parts of the same coin. You can start on the left-hand side. So if I don't have an intervention, or if I have an intervention that has been applied in other settings, but I need to adapt to my settings, I can start with the model for improvement so that I can create the appropriate intervention that is a fit for my context. And then I can move to the implementation side and develop an implementation strategy that will allow me to effectively implement that intervention. But I could be in a different space. I could be where I am trying to implement an evidence-based intervention, and I'm finding that evidence-based intervention, that I am unable to implement that intervention because the intervention is not a good fit for my context, right? So in this case, I'm starting on the right-hand side. I'm starting with trying to implement, but I'm discovering that in order for me to implement better, I actually have to come back to the intervention itself. I have to come back and change and adapt the intervention so that I can have an intervention that is a better fit for my context. So there might be situations where I'm starting with an implementation problem, but I'm discovering that I need to come back to the left and change the intervention in order for me to affect this, in order for me to come up with an intervention that can be implemented. And so it is this dance between the implementation and the improvement side that I want you to be thinking about. The fact that ultimately, when we think about doing successful improvement, we cannot do successful improvement without thinking about implementation at the same time. And so we're beginning to think about these as what we call implementation-informed improvement, or implementation-informed interventions, or implementation-informed change solutions. I need to be proactively thinking about implementation as I am thinking about improvement. And therefore, being able to use this model for improvement and implementation to simultaneously optimize between getting an intervention that is a good fit for my context and developing implementation strategies that will help me implement this intervention, and using PDSA as a way of testing out these solutions in my context. That's been an approach that we have been discovering is working for us. This is the last slide that I'm not going to go over in detail, but this basically takes this general idea and presents a roadmap about how it can be used. And so you could, if you're beginning to think about, as you're thinking about, where am I? Do I need to have a change solution or an intervention, or do I need to do an implementation? It'll help, this kind of roadmap helps you to think about where in this model you want to start and where you land up, and how do you use this model in an integrated way to think about both improvement and implementation. So it is 10:54. I think I have reached the end of my time for my presentation. Thank you very much for listening to me. I hope this was useful and practical, and I look forward to our question and answer session. Thank you.